Hey, good afternoon, everybody. Thanks for hopping on for our monthly stars meeting. Happy Bastille Day to those who celebrate. Those who celebrate are probably all watching the FIFA French soccer game right now. But we're gonna run through. I got a couple case reviews put together for this month, and we'll run through our normal updates and some education opportunities that are coming up. So first on our case reviews today, we have a kiddo back here from June. This is a new STARS patient who unfortunately did suffer a traumatic brain injury. And so kind of a consequence, or sometimes the body does develop autonomic storming after that. And this kiddo is actually currently, as you can see, staying out at Rankin Jordan for his continued post-trauma care and unfortunately was experiencing some increased storming episodes. So this was actually a transport team transfer back to the hospital. So sometimes they do that for the justification with no local 911 on those. And then you can see just kind of some of those standard problems that come with increased storming episodes for kind of generated this call. So to just go touch on that real quick. This is a topic we had covered in some call reviews a number of years ago, but it's been a while. So I just wanted to kind of bring it back up. And unfortunately, kind of where a lot of these kids come in is they sort of have just that autonomic failure, somewhat due to the neuro injuries, albeit I think the mechanisms aren't fully understood yet. But it falls underneath the umbrella of dysautonomia. And of course, there's a couple of other ways you can get to that as well. And we do have a few of these other diagnoses in stars as well. So just a little bit of back to AMP 101. Of course, we have our sympathetic and our parasympathetic that keep us balanced in life. And so whether you're doing the fight and flight or the feed and breed, we of course have all these systems working against each other. And the challenge that these patients get into is that they just start to ramp way too far into their sympathetic side. And that's what causes a lot of their symptoms that we're going to see. So the kind of autonomic storming is like a common name, but the official category is the paroxysmal sympathetic hyperactivity. So with suddenly caused sympathetic hyperactivity. And this has been the definition for about the last decade now. Like I said, it's not fully understood what causes all of these, but a lot of times their episodes are triggered by different stimuli, either external or internal. So for instance, whether that's, temperature changes external to the patient or even a common one you'll see in some of the traumatic brain injuries is, for instance, like if their bladder gets too full. And as you might guess, the fix for that is actually to go in and use a urinary cath and bring that back down so that they'll come out of their storming episode. So some of the most common symptoms that crews would expect to see for that, just, tachycardia, especially persistent tachycardia, hypertension, and then tachypnea are kind of usually the initial starts. And then as it progresses, so definitely diaphoresis. And for any of you who've done transport med before, like you've taken that nursing home patient who has some of this, right, and they just sweat no matter what the temperature is. And it really can be to the point of dehydration and volume down for them as well. Fever will be there, albeit a lot of times it's not super treatable. Like you need to fix the storming, as opposed to like being an infectious cause on the fever. And then when it really gets super bad, they will actually start to get a lot of muscular contractures, and it can almost mimic seizures. A lot of times with sympathetic storming, it's bilateral, it's both sides of the body. But in good news for you, if you were not sure and you thought it was a seizure, a lot of times benzos are part of our autonomic storming algorithm as well. So you won't necessarily go wrong if you treat it as a seizure. So just kind of to talk through that as far as treatment for these patients, they usually, almost like a seizure plan, a lot of these patients will have a neurostorming plan in place. And that starts outside of medicines with just like reducing whatever the stimulus is that tends to cause their storming. And then they're on a lot of baseline medications that will hopefully help reduce these episodes as well. And then on top of all that, there will be an emergency plan if they do start to exhibit the storming, where that's kind of focused on sedation or cutting into that sympathetic tone with beta blockers and things like that. And then you do want to treat the fevers as well. So just to give you a sense, this is directly from the patient that we started talking about. So he at baseline, he's on a lot of medications to try and prevent that storming. And then if he breaks through, we of course potentially will have to go to his emergency plan. And so this is specifically out of that patient's storming plan once again. So trying to do the non-pharmacological measures first to address that. And then first line for him is clonidine, then morphine, and then gabapentin. So just to kind of follow up with that, this is actually the crew prior to their transport. The facility staff at Rankin there did give the clonidine, as you can see, to try and kind of match the plan. And then they ended up transporting. Just of note, like you can kind of see that in this kiddo's vital signs as well, right? Like he's tachycardic, he's hypertensive, and he's running a temp. So, which can be really hard to pull out because, of course, these patients are often also bed confined with indwelling medical devices. So you're trying to rule out sepsis as well. But just know that a high temp often tends to come with these as well. So you're trying to treat the fever. And that's what they did note. And I'm seeing more and more of this from transport team, but also from your EMS crews of like actually noting like ambient temperatures and what you're doing, your patient's temperature, ambient temperatures, and then what you're doing to try and help adjust for that patient. And so you can see the crew there definitely documented their attempts to try and help the patient environmentally. So so I just thought that was of note, just a quick chance to rehash autonomic storming there just a little bit. And so I'm happy to take any questions regarding these patients or these kiddos. No worries. And then I would have just a couple more, and the next two are going to be a little bit related. For whatever reason, here this past June, we had a couple instances of displaced central lines or broken central lines. So I just thought I'd take an opportunity to review that as well. So for this kiddo, like I said, we're getting a lot more of now I don't know how much of this is provider written slash computer assisted written, but to tell me about the weather, on the day you ran this call. So like I said, a little bit more on the ambient temps, but mom was attempting to do infusions on this patient's central line and just noted it to potentially be displaced. Something seemed wrong with it. You can see that the crew found them. Fortunately, there was no significant bleeding from the insertion site or the device or anything like that. They just noted some trace bleeding. They did know that this patient had a distended abdomen, but that was normal for them. And just very appropriately so, the crew acknowledged that this was beyond their scope, which is important, obviously, to know the limits of what you're supposed to do or not do. And we are not in the business of reinserting central lines in the field, so good call not to do that. And so they did end up transporting this patient. So this was in the ED, this picture here on the left. You can see that was kind of the trace blood that they noted. That did end up being the line was actually ruptured right there, just proximal to or where it kind of transitions from being, a thick lumen to a thin lumen there. And so this is the kiddo who came in. He has his central line because he's got shortcut syndrome. So we feed him his nutrition and his TPN through his line all the time. And so they did end up having to fix his broviac while it was in. And then this was the discharge photo where you can see, and I have some better pictures of this coming up in the next couple slides, but something you should see on the broviacs, which are the ones that are on the chest wall there, usually some looping, and that's to give you a little bit extra line. So in case it does get pulled, you've got some room to play with there. But an important thing is that the thin line should always be underneath the tegaderm. And so that's what it should look like whenever they discharge to go home. And then I was just going to do real quick. This is actually so just a few days later. This was another one, another actually Rick and Jordan. So this isn't just like happens at home. This can really happen anywhere. But a suspected broken Broviac line. And then one thing to always kind of pay attention to is like, why do they have the Broviac? Is it because they get antibiotics frequently? Is it because they're getting some sort of infusions, maybe for chemo or something like that? Or is it because they're TPN dependent? And that's only important because if they depend on us for their nutrition and coming through this line and that gets interrupted at all, certainly want to be worried about blood sugars potentially dropping or anything like that. So just always kind of important to ask ourselves like, oh, why did somebody take the time to place that medical device inside your body? And because that can inform the next emergency. So this kiddo was being brought to us just to get it fixed. Along those lines of, okay, how are we maintaining our blood sugars? Because if you're TP independent and that goes away, your blood sugar can kind of drop pretty quickly. And so they said, oh, well, we established a feed through the G tube then. And so they were able to maybe potentially get a little bit of sugar absorption, even though in the short good kiddos, there's a little bit of question how much they're getting. So just to talk about the Broviac lines in general, just some updates that even we've made some recent changes after talking to our surgical team. First of all, this is the device, like I said, that goes in the chest wall. It's usually on the right side under the subclavian, into the subclavian vein there. And it's still a venous line, but it's a central venous line as opposed to the peripheral IVs. A lot of our providers are starting. And as I said, just what you kind of should expect to see is the majority of the thin tubing should be underneath that tegaderm. So if one of your crew members is looking at that, that's what they should expect to see. And so also the coil will be to the side. So you should be able to also get a good visual on the insertion side to see if it's infected or swollen or anything like that as well. There'll be some steri strips holding it underneath the tegaderm and then the tegaderm over the top of it all. So just some special things to think about, especially for my ED staff on here. Obviously we want to keep the antibiotic filling or going through the whole lock. And then as far as just a couple other things that apply to EMS as well, we're going to get actually to that on the next slide. So one of my things on this is to just point out, like sometimes our crews go run these kids, right? And they're like, what are these poor parents doing? Why are they struggling at home? And I just want to point out, like, these are actually the rules for our surgical team in-house, the number of people it takes to do this and to try and do it right. And so just once again, that like, it's cool that our kids get to go live at homes with their families, but if they're not getting, in-house nursing hours filled to help them with all of this, and not all home nursing agencies are created equal, we're asking a lot, right? Like this family is trying to perform like really tough roles within the hospital to maintain these medical devices sometimes, and this is just what we require here within our hospital. So just to kind of always reiterate that. And then the final component I wanted to put on that is something that you'll see in the wording, but another thing is you always want to use 10 cc syringes. We don't use anything smaller whenever you're using these for medications. And I'll talk to that more on the next slide, I think. And then finally, for my real little guys that are going home, some of you have seen this when we bring out the blue training bags. We have some practice Gus gears on them. But as you might imagine, with our real littles, like it's not a good idea to have some sort of wire or line that they can grab and pull on. And so they have these vests that'll go over the top and help Velcro down over the top of that, so that the kiddo can't mess with it too much. And so just you might actually encounter a kid who's got some sort of vest looking device on to help protect their central line there. All right. So just some things that I said that have changed, and you will see for any of you who have kids with broviacs in your kid pool, some things that will start changing in the notes. A little bit of change. We used to only say just clean it for 10 seconds. The official rules are 10 to 30 seconds, so we'll kind of honor the official line of either an alcohol prep pad or chlorhexidine. You do have to allow that to dry. And then we're writing in the language to the STARS plans of only 10 mil syringes or bigger, and also flushing with 10 mils normal saline for any medication that you push through that. That's obviously not super common. For the most part, what we're recommending crews do is, of course, IV access first if the kid's critical IO access because you feel comfortable with that. But of course, like if we're in a truly critical situation, this is an available line that could be used to give medicines, especially cardiac medicines, for resuscitation. And so we do write in the instructions, crews, if needed, have the ability to access this. And so just we're going to add in there as far as the element of needing to use bigger syringes, just because some of the real risk, first of all, you have to make sure the medicine gets through it. And then also a lot of cognizance and carefulness on making sure there are no air bubbles in the syringe whatsoever, because we are going straight to the heart and straight to the lungs out of this, and so you of course don't want to introduce an air embolism. All right. Any questions about the broviacs or the central lines? All right, then we're gonna just run through the numbers real quick. So we did add 23 more kids since our last meeting there in June. And you can see as far as logins, dispatch agencies have now almost completely won. Just Melanie's hanging on there at the very end. So somebody get after one of your friends to pass her this year. As far as dispatches, we had a ton of dispatches for June. Some of that is Golisano was setting records down there in Fort Myers, but still it's pretty strong up here as well. So a total of 77 dispatches in the month of June. We had 49 known 911 transport calls. You can see, unfortunately, our numbers have kind of dropped off, or we're really holding, unfortunately, at this steady state as far as people referencing whether they knew they were on a STARS call or not in the trip sheet. We did have a huge number of non-transport calls for June as well. So 16, some of that, we had a couple seizure kiddos who are really seeing an increase in their seizure activity. Unfortunately, some of their medication regimens aren't holding, but crews were able to assist family, get it under control, and just kind of observe and let them follow up with specialty or with their specialist. So that's kind of to explain the increase for June on that. And then as far as just still only about 50-50 on the whether people noted whether they were on a STARS call or not. As far as airway management, as part of that, we did also have a ton of trachs managed in June, and including some really good stories. So most of EMS's was like, as far as just helping and suctioning and using it to apply oxygen. Did have a couple cases of like family doing the change first and then EMS just maintaining for the transport afterwards, which is certainly a win for the discharge coordinators and probably a win. Most of my EMS providers, I assume, would consider that a win as well if that's taken care of prior to your arrival. As far as medications are actually down pretty far. So just a couple drugs given for the month of June. And then just continuing to see just that overall growth across the system. I do think we'll hit 2,000 patients before too much longer this summer. And then we, of course, are still watching as far as when the kids stop at an outside facility, and just kind of seeing, how long they're there before a transport team or another transporting agency comes and grabs them, and just kind of tracking outcomes on those, including the outside hospital times there. As far as some upcoming trainings, so we did run our first train the trainer course there in May. It was well received by the people who were able to attend. So we are going to run that back again this fall. I have one in October that will be in Southwest Missouri down there with Cox Health. So looking forward to that. And then we'll have another one here in the St. Louis area in November out at our sim center as well. So next meeting or two, I should have all of the LMS stuff built out for that, and we'll start to get people registered. So just wanted to put that on people's radar screens so that they are aware, though. And like I said, I think that'll hopefully kind of be a positive way to keep getting this information out into the world. So cool. I see your message, Mr. Robert, there. And then for anybody who needed to request our education team to come out, please feel free to scan this. It'll take you to a Microsoft Forms, and you can kind of give us the dates you were thinking of and any topics that you want us to bring out. So I'll go ahead and leave that one up for a minute. And then let's see, besides the note takers, nope, that's all note takers. And then Mr. Robert. And Robert, I see your message. I'll give you a call after this. So that was everything I did have prepared today, but I certainly have some time here for open questions or comments or concerns.
Hey, Nick.
Yeah, what's up, Ryan?
Hey, it's Ryan. So I don't know if we have anyone from Melville on, but this has to be a positive if I'm mentioning the name. So I did get, I'll reach out directly, like to the crews and do a little more formal, but I wanted to give a general acknowledgement to Melville. They have a kiddo in their area that over the last month he has a VP shunt among other things, and he has had some shunt malfunctions. And from the family and also some internal caregivers at our hospital, I received some positive input. The family actually would like for the responding crews to be more like formally recognized. They said that from the family, they said that it was obvious they were well prepared and were kind of well versed in the care plan, but they did also reference the care plan. And they provided excellent care. And then from our in-hospital providers, they stated that each time this kiddo was transferred, the care that he received was fruitful in him arriving, in better condition than he might otherwise have. So if anyone from Melville is on, kudos to your crews, and I'll be following up with more specific, like to the individual crews and things. But I just wanted to give that shout out to them on this meeting.
That's awesome. Thank you, Ryan. That's some good close circle stuff. Cool. Yeah. And I see Dr. Kluge's also put in as far as about how quickly the kids coming off their TPN can plummet their blood sugars. And so, yeah, absolutely. Just that's like going to be standard of care if they come off the TPN. It's one of those I can't give you a rule for all situations whether you can keep the TPN going for transport or not, depending on your locality and patient situation and all that. But just be aware if for whatever reason they have to DC it for transport, keep a real close eye on that. So. Any other questions or comments? Well, I appreciate all of you. Morella, you have a question?
Talking to me?
I was not.
I'm just kidding. Hey, yeah, just a reminder for anybody who may need some easy IO education, you can reach out to me, brian.schmeling@teleflex.com, or, reach out to the Teleflex customer service line at myteleflex.com, and they can hook you up with my contact information. So I'm working with Michaela to get something scheduled with your ER soon. So we're going to get that done. And, generalized questions about anything IO, you can shoot that my way.
Awesome. I appreciate that, Brian. Thanks for hopping on today.
Yep. Yeah.
Cool. All right. Well, hopefully nobody will come at me with pitchforks if I let you go a few minutes early to go about your day. But I'll hang on if anybody's got anything else they want to talk about. And I wish everyone else a good day.